Today I am going to discuss a new method for distal locking of intramedullary nailing. We named it as push with hand, a novel, effective and reproducible technique. Why it is required so? Because this step is very critical for the stability of the fracture and the stability of the lock procedure, and also it takes at times it can be difficult procedure, especially for the beginning, and it can take a lot of time, effort, and more so the radiation exposure to the tune of 50% of total radiation exposure in the surgical procedure. So that is the reason there are various techniques are already described with various limitations for this particular technique. So if I just going to run through the various techniques, there are freehand technique, there is a radiolucent aiming device, nail over nail technique, K-wires using the jig, but invariably it can be inaccurate because of the deformation of the nail because of the curve of the bone. There are also other methods described like using targeting device, navigator computer assisted, using laser guided device, cannulator drill system, dual insertion of the nail handle, nail mounted guide. There are also self-locking nails and use of set screw. And set screw, you have to remind that it gives only 87% of the torsion stability at the max, not more than that. Other technique like using Steinman pin, use of radiolucent drill, electromagnetic tracking device, data targeting system. This is just an example of nail over nail and using a K-wire and struggling for doing this nail. This is an example of self-locking nail. They are rare, not freely available in the market, and also their strength stability may not be necessarily very good. Also there is a role of AI by use of augmented reality based navigation. This is an example of nail over nail technique. Another example of a fancy device from Smith & Nephew called as Trigon device for this particular lock. There is another example of another fancy device, another example. And meta-analysis have suggested that electromagnetic technique is better than freehand method, but obviously it is expensive, it is cumbersome, and cannot be reproducible or available in all the settings. So what are the problems? Actually, we are using a 2D image for a 3D procedure, and that is the reason it can be tiresome, it can be time consuming, and it can be inaccurate at times. So these problems can lead to excessive radiation, damage to the bone with multiple attempts. That is the reason there is a clear need to develop a technique which should save time, decrease the radiation exposure, and should be reliable and reproducible and easily done by an average or beginner orthopedic surgeon as well. So our technique is push with hand, which means we have to insert the nail using all the standard procedure technique, whatever we do, whether we are doing nailing of any long bone, be it femur, tibia or humerus. After that, particularly in femur fracture, we must decrease the traction, and we invariably have to abduct the limb so that the C-arm can be rotated properly and can be positioned properly. But mind you, this is a very critical step. You must release all the traction before abducting. If you are not going to do so, you are going to create a distraction at the fracture site, and which is good enough cause for creating a non-union in the long term, because at the end of the day we have to remind ourselves that our target is not to finish the procedure but also to make this fracture to heal. So that distraction has to be avoided by loosening all the traction, and also be careful the groin get exposed while abducting, so the drapes has to be carefully handled at that particular step. Then you must check in AP at the fracture site whether there is any distraction. If at all there is a distraction, you must do all the maneuvers of pushing or thumping to decrease any distraction if at all has happened. Or ideally speaking, you must be doing distal locking first, so that you have to do back hammer to impact the fracture, especially in a transverse fracture, but obviously cannot be done in cases of comminuted fracture. You must check obtain a perfect circle in the lateral view. So you have to position the C-arm accordingly and try to do not start the procedure of locking if you cannot obtain a perfect circle as in example shown. And for that you don't have to rotate the limb, but you have to rotate the C-arm, so that has to be positioned properly. Then start with the stab incision, but also go deep with a knife so that you can cut all the deep tissues, so that should not become hindrance to the free placement of your drill bit. Otherwise that is good enough cause to cause problems. Scrap the periosteum with a small hemostat, so that otherwise the drill bit is going to be slipping, and that's not going to be good news. Start with the drill bit, keep the tip of the drill bit at the angle of 60 degree approximately, because you cannot be placing it at 90 degree because the C-arm is coming on the way, your hand will be there, the handle of the drill is going to be in the way, so you have to start with a 60 degree angle, but ensure the tip of the drill bit is perfectly in the circle, in the center of circle, and there should be clear visible space all around that circle as shown in these images. So initial placement of the drill bit is very correct. Keep it there firmly with a pointed tip, and then try to bring the drill bit and the position of your hand 90 degree to the end bone, so that you can be perfectly into the hole. This is the correct initial position of the drill bit, and this is another example of showing the correct position of the drill bit. However, this is the position which is incorrect. You see there is eccentric placement, it is not perfectly in the center, there is no clear white circle around the drill bit tip. This is another example of incorrect placement of the drill bit. Another example on the left side is incorrect placement of the drill bit, whereas just try to deviate slightly, I've shifted and that has become in the center, and that is the correct position. So you should not be starting without placing your tip of the drill bit exactly in the center of the circle. And this is, once you drill the proximal cortex or the near cortex towards you, then you disconnect the handle of the drill from the drill bit and recheck on the lateral view, and that should be perfectly like this. There should not be any eccentricity. It should be perfectly in like this, and then you must, after drilling, you must check it. Once it's checked, everything is clear, you just push with the hand through the hole towards the opposite cortex, and then reconnect it with the drill bit with the drill guide, with the drill machine, and then drill the far cortex, and your procedure will be done. This is an example of incorrect placement of the drill bit. Another example of incorrect placement of the drill bit after drilling the near cortex. So this is not into the hole as you would have liked to. So this is the time where our technique is going to come into the picture. So what happens is, whenever there is eccentric placement of the drill bit, you know that this is not in correct position, so you don't have to panic, don't have to restart drilling and repositioning. All you have to do is withdraw this drill bit with the hand only and reorient. If it is going posteriorly, try to redirect it anteriorly. If it is going to proximal, try to redirect it distal, and vice versa, and then push it through the hole and towards the opposite cortex. Recheck on the lateral view. Like this is an example, this was going laterally, and just I have to redirect it medially toward the center of the hole, and it perfectly placed without actually re-drilling or restarting the initial pilot hole or the near hole, and this is perfectly placed in. This is just an example of how we do intraoperatively actually, and this is very simple maneuver. All you have to do is just slightly withdraw it, don't withdraw it fully, and withdraw it to the near cortex, and then adjust it, pass it through the hole of the screw or hole of the nail, and advance it to the distal cortex, and then reconnect with the drill machine, and then drill it across. Another example of the similar maneuver, the drill was going anteriorly. What I've done is withdrawn it, pushed it, adjusted it slightly posteriorly, further pushed it, and then everything is taken care of. This is another example of doing the so, and this is pushed through the hole up to the distal cortex, and then obviously you have to check the screw also after measuring. Once you drilled across, you obviously withdraw the drill bit, you check it with the depth gauge, measure the correct size, insert the screw, but also once you're inserting the screw, tighten it but not fully till you can actually see the tip of the screw just about to miss the tip of the screw. Then you disconnect the screwdriver, recheck under the C-arm that it should be again perfectly in the center, and then advance it. If you're going to already fully tighten it, and if at all you have to readjust, then it will be difficult to locate it or then pull or withdraw it because of the soft tissue and because of the depth. So it's better time saving that at that stage you check, advance it fully. Then obviously if you are doing two, obviously you have to mostly do that at least two distal locking screw. Similarly, same maneuver you have to repeat it for the next screw without going to the AP view at this stage. And then once you're done with the second screw as well, you swing over to AP view and then obviously check for the correct length. If there is any error, obviously at this stage you can check, you can always rectify, and your procedure by this will be done. So other tips of doing this correctly is try to use a shorter drill bit to avoid the interference with the image intensifier, and the tip of the drill bit has to be really very sharp. Don't hammer across, however, especially the opposite cortex, but that will lead to comminution and damage of the bone, and obviously that will increase instability as well. Our technique is simple, it is more effective, it is reproducible, time saving, obviously less C-arm or image intensifier radiation exposure. It is reproducible, it is cheap, no special extra equipment needed, no extra assistance needed. It is consistently successful and reproducible. Thank you very much. Thanks a lot.